In this video, I'm going to be talking about trichoblastic tumors, and most of the cases were shared with me by Antonina Kalmykova from CSD Healthcare in Kyiv, and so I thought it only appropriate that I record this as a joint lecture. Now, trichoblastic tumors are often confused with basal cell carcinoma, and that's probably the most difficult part of the topic, and is particularly important not in the context of benign lesions, trichoblastoma, but when one gets to into the territory of trichoblastic carcinoma and trichoblastic carcinosarcoma. These are best regarded as high-grade tumors, and so it's very important that one doesn't mistake a BCC for a trichoblastic carcinoma and vice versa. And what I want to show you in this video is the ease with which you may distinguish the two on the basis of just using H&E. I know there's a lot of immunohistochemistry available, and it can be nice to sometimes confirm your H&E diagnosis, but by and large, I think these are readily recognizable on the H&E. So I'll just get this into screen show, or slideshow rather, and we'll get started. So this is a lovely low power view of a tumor that's almost biphasic, with trichoblastoma on the right and something that looks a bit more trichoepitheliomatous on the left, but I think they're all one tumor, and it's just different patterns of the same lesion. Now, trichoblastomas are very rare, and that's an important point. I think you're going to see hundreds of BCCs before you come across a trichoblastoma. But they can look very similar to BCC, and as you see in that picture on the right, it's an erythematous nodule with, I think you can make out blood vessel coursing over the surface of it, and I'll show you the dermoscopy of that image in a moment or two. In my experience, they most often present on the head and neck, and particularly on the scalp. And I think a lot of them, because they arise in nevus sebaceous, that's probably why the scalp is such a common site. But you may get them pretty much anywhere on the body, on hair-bearing skin. And now the facial plaque variant, I have no experience of, to be truthful. But from the literature, people sometimes regard this as representing a low-grade trichoblastic carcinoma. And if anybody watching these videos has seen an example, they might like to let me know and share it, and we can have a look at it together. I would like that very much. They tend to be rather big. I mean, this is a small one, but sometimes they can be 4 or 5 centimeters in greatest dimension. And interestingly, trichoblastoma is not associated with Brooks-Spiegler syndrome, but trichoblastic carcinoma may be associated with Brooks-Spiegler syndrome, well, at least in one case it was. So if you're wondering whether a lesion is a trichoepithelioma or a trichoblastoma, it's probably important to make the distinction, because you know that trichoblastoma is not associated, does not have that association. And I think Antonina and I did a video sometime earlier on trichoepithelioma, so I'm not going to go into it now, other than suffice it to say trichoepithelium is superficial and often has a racemose and antler-like configuration with loads of keratocysts, which is quite different from the large nodules that one sees in trichoblastoma. Mind you, having said that, some people regard them as variations on the same theme, and that's fine. I don't have any great feelings either way. So this is a case that Kim Hiatt shared on McKee, a lovely, very well circumscribed nodule on the back of the thigh. And this is one on the scalp that I saw in the literature of a trichoblastoma associated with a dilated pora vena. And I think this is the dermoscopy of the first lesion I showed, and it really does highlight the vessels coursing over the surface of the lesion, very like a BCC. And then I found this patient such a terrible affliction with I would have wondered whether those were all trichoepitheliomas, you see, but according to the pathology shown, it was trichoblastoma, but it may be a mixture of the two, I don't know. Now, trichoblastoma is very easy to recognize on H&E, and it's very easy to distinguish from BCC for two reasons, really. One is that trichoblastoma is a biphasic tumor. It's composed of epithelium, which shows the peripheral palisade, but does not show a retraction artifact and does not show mucin within that retraction artifact. And then secondly, it's associated with specific follicular mesenchyme. And this one, some people, I think, use the term continuous dermal papilla. And you can see why that works, is it goes all the way around there and all the way up there. And that's more mesenchyme there, almost forming a sort of a papillary mesenchymal body. And it's important to note that trichoblastoma can have an awful lot of mitotic activity, and it doesn't mean it's malignant. You need to find other features of malignancy, such as atypical mitoses or necrosis and so on. And I think that's a catch for the unwary. It's a bit reminiscent of pilomatrixoma, which again is one of those tumors that can be mitosing like fury. It doesn't mean anything. So always think of things in context. And there's a sort of a classification of trichoblastoma, which trichogerminoma, I'll show you a bit of one of those later. Trichoblastoma can show clear cell change, and we'll see that. Sebaceous differentiation. I'm not going to include trichoblastoma with adamantinoid features in this talk because it's sufficiently unusual that I think it merits a video of its own, and the same thing goes for panfolliculoma, which some authors include as a variant on the theme of trichoblastoma. And the other thing, another way of distinguishing between BCC and trichoblastoma is Merkel cells are an almost invariable feature of trichoblastoma, as we'll see later. So here's an absolutely gorgeous, drop-dead gorgeous image that Sheri Dorji shared with us on McKee. And just look at this. Isn't this a beautiful image of I think this is facial skin, and there's some muscle at the bottom, and there you've got a pretty well circumscribed tumor composed of varying size but quite large nodules extending pretty close to the epidermis down to subcutaneous fat and almost touching, well, actually just touching muscle. So if you were thinking of trichoepithelioma, it sits up there. You see, it's a superficial tumor. This thing goes all the way down there. So, in that, if you were having that discussion, that's how you know this is trichoblastoma. And there's a slightly closer view showing that the tumor's biphasic. It's got the basophilic nodules of cells, and then in between there's this specific stroma going around everything. So that view tells you this is trichoblastoma and not BCC. And there it is going down to the depth of the lesion. And there it is showing keratinization. And here's a field where you can see a few sort of cystic spaces which are a bit reminiscent of adenoid BCC, but then we don't have any retraction artifact and we don't have any mucin. And there's a field there highlighting another area looking a bit rather like adenoid BCC, but notice the absence of retraction artifact, and right in the middle there's a small focus of sebaceous differentiation. But it's important not to look at that and say, oh, this is sebaceous carcinoma. That would be a very bad mistake to make. And here we see, this is a bit more superficial, where we've got keratocysts, and in the middle you can see a focus of apoptosis, which can be quite common, quite pronounced in this tumor. And there are the keratocysts. Now here's another one. This is a lovely case that Antonina shared with me, and it's remarkably similar to the previous one. It's a very discrete, circumscribed nodule extending from just below the epidermis into the deep reticular dermis. And here you can see the basaloid cells, peripheral palisading of trichoblastoma, no retraction artifact. And you can make out here the stroma is very harmonized and eosinophilic, and you can see some eosinophilic material within the within some of these tumor lobule or epithelial islands. And I don't have a Congo red, but I'm pretty sure that's amyloid. And there's a close-up view there. This is slightly out of focus, unfortunately, but I think we would find if we did a Congo red that that's tumor amyloid, which doesn't mean anything other than it's something that you might see, and there's calcification in the middle. And then this is another one that Antonina shared with me, and it's a rather nice case because this one does show an epidermal origin, which is typically not present in trichoblastoma, but this surface superficially looks a bit like a trichoepithelioma again. So maybe sometimes you can get a hybrid tumor, which would, I suppose, support the argument that these are just variations on the same thing. And there we have a close-up view there, and sometimes you get a crack developing at the edge of the islands, but this is not a retraction artifact as such. And there's a close-up view there showing lovely palisading. There's this specific stroma growing around the tumor. There it is there. And so this field on its own is diagnostic of trichoblastoma. And more of the same with the keratocysts. And this was in the deep part of the tumor. There was a lot of melanin pigment, so this clinically would have presented as a pigmented nodule, and it might have raised the clinical differential of melanoma. And here we have, this is the tumor that I showed you at the very start of this talk, with the clear trichoblastoma at one side, and then this rather more racemose and antler-like growth pattern of the epithelium, with lots of keratocysts, looking more like a trichoepithelioma. And there we have that's really a nice view of the junction of the two components. And this is the very trichoblastic bit. And I just wanted to draw your attention. Sometimes the islands are sort of homogeneous, but in other ones you get striking pallor within the center of these nodules. And when that becomes very marked, people sometimes use the term trichogerminoma, but it's not a term I like. I don't think it actually helps anybody. It's just splitting for the sake of splitting, in my view. And this is a nice field. If you can see my arrow at the bottom, just on the following it along, you've got this continuous follicular stromal component. There it is again, and it almost follows along the whole base of the lesion. So that's absolutely gorgeous. Now, more of the same. And this one, just to show you mitoses in a trichoblastoma. So it's best to expect them and not to worry about them too much. And there are the keratocysts. And this is the view that I showed earlier on, where we've got this stroma. And as I mentioned, the stroma just follows all the way along. So that makes diagnosis of trichoblastoma child's play. However, if you want to do him, this is that tumor stained for BCL2, which is labeling the cells at the periphery of the lobules or the tumor nodules. And here we see Burr EP4 staining all of it, all of the epithelium, that is, and CD10 highlighting the stromal cells, which is really nice. But then CD34, which should have been staining all the stromal cells, isn't. I think these are just blood vessels are getting picked up, so that was a bit of a disappointment, but doesn't change the diagnosis, I must say. And this is nevus sebaceous with the sebaceous glands in the top left-hand quadrant. And you can see the tumor wide. People used to think these were BCCs, but when you look at it again in the context of the stroma, you can see this follicular stroma going all the way around it. So that's clearly not a BCC and is in fact trichoblastoma, which is the commonest tumor that we see complicating nevus sebaceous. And there's a good one there. This is a lovely example with high-level sebaceous glands draining onto the skin surface, and apocrine glands, ectopic apocrine glands. And over on the right you see a pigmented lesion. And again, I'm sure that caused alarm clinically for melanoma. Now, how do we tell the difference between a trichoblastoma and a BCC? Well, on low power, this is a case of Antonina's, you'd be very hard pressed to know which that was. There's nothing terribly distinctive at this magnification, so I'm quite happy to say it could be one or the other. But when you look at it closely, you see the retraction artifact and you see the mucin. So when you find mucin and retraction artifact, you know it's a basal cell carcinoma. Now, I thought this was quite a useful panel that I borrowed from Patel's article in Curious, and this is really for the immunohistochemistry enthusiast watching the talk, and it's actually quite nice because there are some either ors. CD10 stroma, positive in tricho, negative in BCC, so that's useful. CD34 does the same, so that's useful. CK20 showing Merkel cells present in trichoblastoma, negative in BCC, and follicular stem cell marker positive in trichoblastoma, negative in BCC. So you've actually got there are 4 absolutes that will make the difference, and BCL2 just stains the periphery of the tumor, whereas the whole thing's labeled in BCC. So if you are having problems distinguishing between the two and you have to use immuno, well, then there you are. And Carlos Cerruto from Florida very kindly shared some images with me. This is CD34. It's strongly staining the stroma, so that's a trichoblastoma. And CD10 is just expressing the peripheral margin, so that makes it a trichoblastoma. I'm going to leave D240 out because I forgot to put that in the table. Dr. Abed presented this lovely case of trichoblastoma, CD10 staining the stromal cells, CD34 doing the same thing, and CK20 trillions of Merkel cells, so that makes life very easy. And this is another one that Dr. Kervarrec shared with a nodule on the scalp. Again, I just wanted to highlight Merkel cells. Mind you, sometimes you can't find them, so they're not a sort of an absolute diagnostic sine qua non. You may have to examine multiple bits, or you can just live without them not being there. Now, malignant trichoblastic tumors they're exceptionally rare. I have seen maybe upwards of 10 cases, and I think they're all, or nearly all, referred consultations, or else they're cases on McKee or on Kiko.com. You're very unlikely to come across one in your life's practice. Maybe you'll see one, maybe you'll see 2, I suppose, but the important thing is don't mistake a BCC for a trichoblastic carcinoma, because a nodular BCC is a pretty low-grade tumor. It's unlikely to do you much harm. A trichoblastic carcinoma has a metastasis rate of around 25% and a mortality of 25%, so it's a high-grade tumor, so it's important that you recognize it when you get one. And the literature talks about dividing them into low-grade and high-grade. The low-grade being that facial tumor that I talked about earlier. I'm not terribly inclined to grade these things at all unless they're obviously very undifferentiated, and then I might say high grade, but I think basically one should call them trichoblastic carcinoma or trichoblastic sarcoma if it's just the stroma, or trichoblastic carcinosarcoma if it's the epithelium and the sarcomatous bit, and recommend a wide excision and check the local lymph nodes, because the carcinomas can not uncommonly go there. So you need to work the patient up very carefully with these tumors. They're not to be taken lightly. And I mentioned this aggressive trichoblastoma occurring on the cheek of females, and all of this really, it just depends on. I'm not quite sure this comment I put in high-grade tumors rise in the background of trichoblastoma. I would personally say all tumors arise in the background. So that may be a little error that, but I'm not going to record this video all over again. And this is a case that Henry Yang presented on Kiko, and it's a lovely tumor. And these are all the cuts. Now, the point I want to make to you about these tumors is they can be very big. Some of them are 4, 5, 6 centimeters in diameter. And so you need to examine an awful lot of it if you're going to go down the grading pathway, because if you call it low grade, the implication is that it's not going to do the patient much harm. But if you've got a great big nodule and you've only examined, I don't know, 3 or 4 bits of it, then you might be leading yourself and the patient down the garden path to disaster. So be very careful. Now, this is an interesting tumor because it's an impossible to diagnose on this first fragment. At least I think it's impossible to diagnose. It's a circumscribed, almost looks as if it's pseudo-encapsulated, so it's a very odd tumor composed of nodules of basaloid cells showing focal squamous differentiation. I think the squamous differentiation is a complete red herring, but it's there, and because it's there, it can fool you. But when we look high magnification, you see, I mean, what on earth are you going to call this? Nodules of tumor cells mitosing all over the place. That may well be an abnormal mitotic figure, quite marked nuclear pleomorphism, but it's sort of, to me, it's a sort of a carcinoma NOS. I'd be very reluctant to say what it was. Tremendous nuclear pleomorphism there and there. So this was a fantastic case. Oh, you can also see this clear cell change, which is a feature sometimes seen in trichoblastomatous tumors. And there's a highlight of the clear cell change. There are 2 mitotic figures in the center, and I think that's an abnormal mitosis in the upper right quadrant. So, what do you want to call this? Well, I suppose with the clear cell change, you might, and that squamous bit, you might have wondered about a tricholemal carcinoma. That would be a good thought. It would be hard. Could it be a metastasis? I suppose it might be. Could sebaceous carcinoma come into the differential? We've not really seen any SIBO sites, but I suppose you could bear it in the back of your mind. But life is actually much easier. That's just another of the same view, because there was a separate fragment of tissue, most of which looks the same as the first one, except up here there's a slight difference in morphology. And if we look at that bit there closely, what have we got? We've got a lovely papillary mesenchymal body, and the epithelial component, the nuclei are just the same as those we saw in the first fragment. If we go back one, you see, look at those nuclei, and then look at that those nuclei, they're just the same. So this is a case of being saved by Henry's processing all of the tissue and a bit of luck. And I think luck is the operative word here, that we found that. So we were able to call it a trichogenic carcinoma. And lastly, I want to just briefly mention trichoblastic carcinosarcoma. And there only are half a dozen case reports of this to my knowledge, and it's hard to make any comments about them really, other than they're as rare as hen's teeth, and they're probably best regarded as bad news tumors. and I can't really say much more about them. This is a nice tumor because you can see the trichoblastoma bit. You can see there's an awful lot of the spindle cell component. It's sort of nearly 50-50. And there, you see, if you look at that view there, there's as much spindle cell proliferation as there is epithelial proliferation. So this is clearly not just a trichoblastic. Well, it is a trichoblastic tumor, but I think there's carcinoma and sarcoma in it. If we look closely, that bit's the epithelium is clearly carcinoma, and this bit is a sort of a, I don't know, maybe they're myofibroblasts, but this is a sarcomatous component. And there's a close-up view there just showing a mitosis and nuclear pleomorphism. And this is very pretty. This is BER EP4, which, as you'd expect, is labeling the epithelial component, but the spindle cell component, as you'd expect, is completely negative. And the same thing goes for pan-keratin. But it just highlights the two cell populations. And then lastly, I'm sorry, this is not very nice histology. It's a bit pixelated, but I had problems getting it into focus. And I don't have any low power images. This is just a rather cribriform component of trichoblastoma, which in this chunk has become anaplastic. And I'll show you. You see, that's that left-hand side with ferocious mitotic activity. In fact, I wondered whether this was neuroendocrine carcinoma, but that didn't pan out as far as I know. So I think this ended up being, in this case, I think it would be fair to call this high grade. And there you see epithelium and the spindle cell component, rather like the last one, but elsewhere it was forming malignant cartilage. And there's a close-up view there. And that's really all I have to say about these tumors. And hopefully you'll be able to make some comments after watching the video and share your experiences. I'd love to know what others of you have seen and wish to talk about. So thank you very much for your time.